The title of this talk is Neuro-ophthalmology. These are the class objectives. You do not need to read them. We will use them to chart our talk. This talk will be conducted using a question and answer format. The first question is: astigmatism is corrected with dash lens. A. Concave. B. Convex. C. Cylindrical. D. None of the above. In the process of answering this question, we will address 4 conditions. Condition number 1, myopia. Myopia is also called nearsightedness. The afflicted can see near objects clearly, but not those far away. When reading, as depicted in some of the characters in this cartoon, they place the magazine close to their face as depicted here, and here. A student who is unable to see the numbers on the classroom blackboard from the back of the class is suffering from myopia. A man that needs glasses to drive but can read without them also has myopia. Eyes of patients with myopia are too long for the refractory power of the cornea and lens, hence crisp images fall short of the retina. This is corrected with concave lens. Second condition, hyperopia. Hyperopia is called farsightedness. As depicted in some of the characters in this cartoon, they hold magazine far away from their face to read them. This one, and this one. An old person who is not able to read a book unless the book is far is suffering from hyperopia. A person that can drive without glasses but need glasses to read has hyperopia. Eyes affected by hyperopia are too short for the refractory power of the cornea and lens. Hence, crisp images fall behind the retina. Hyperopia is fixed by convex lens. The third condition is astigmatism. Astigmatism is defined as different refractory powers at different axes. Astigmatism is due to abnormal curvature of the cornea, causing multiple images in the retina. Astigmatism is fixed by cylindrical lens. The fourth condition is presbyopia. Presbyopia is defined as an aging-related impaired accommodation. It is due to changes in lens elasticity, changes in lens curvature, and decreased strength of the ciliary muscle. These factors bring about an inability to adjust to changes in angle of vision. It is fixed with bifocals, so a person can achieve good vision by looking up or down and adjusting their angle of vision according to the proximity of the object they want to see. So the answer to this question is C. Next question. Eye alignment should be tested in dash positions: A6, B9, C3, D2. Eye alignment should be tested in primary position, looking to the right, looking to the left, looking up, looking down, looking right and down, looking left and down, looking right and up, and looking left and up. So the answer to this question is B. Next question. Right superior oblique and left inferior oblique are tested with the patient looking right and up. A true, B false. The evaluation of patient's extraocular movement is performed to exclude or detect weakness of the extraocular muscles, and if weakness is found, to single out the muscle involved. This is achieved by asking the patient to look in the directions we previously mentioned, while the examiner considers the muscles being used at each position and strives to isolate the functioning of each muscle. Extraocular movements are performed by contraction of 6 muscles in each eye, hence 12 muscles. These muscles work either in pairs, in which case picking the affected one is easy by noticing which is the involved eye, or in groups of 4, in which case picking the affected one is harder, as you soon will see. Notice that the muscles in the right eye are colored, whereas those in the left eye are labeled by their initial, that by now you can easily recognize. So now let's go back to the patient. When the patient eye are in primary position, that is looking straight ahead, the patient is asked to look to the right. In normal situation, both eyes will move simultaneously due to contraction of the right lateral rectus and the left medial rectus. If one of the muscles do not contract, we will notice that one eye does not move, thus the affected muscle will be readily singled out. When looking to the left, the eye muscles contracting are the left lateral rectus and the right medial rectus. Again, singling out the malfunctioning muscle is easy just by figuring out which is the eye affected. When asked to look up, the right eye, superior rectus and inferior oblique will simultaneously contract, and the same muscles will contract in the left eye. Here we have a problem, since 4 muscles are involved in the same movement, 2 in each eye. Singling out the affected eye will only narrow the possibilities to 2 muscles. So the question is, how can we tell which of the 2 muscles is affected? But before answering this question, let's look to see what happens when we ask the patient to look down. When the patient looks straight down, the right inferior rectus and the right superior oblique contract, and the same muscles contract in the left eye. Again, we are faced with the same problem we found when testing upward gaze. That is that 2 muscles are involved in the same movement in each eye. So how can we determine which of the 2 muscles is affected? The answer is easy, by asking the patient to look to the side and then to look up and down. So if we now ask the patient to look to the right and then up, the muscles used by the right eye to do so are the right lateral rectus and superior rectus. Since you have already tested the right lateral rectus and you know it is fine if the patient cannot look to the right and up, and the eye not functioning is the right eye, you know that the problem is in the right superior rectus. In the left eye, when looking right and up, the patient is using the left medial rectus and inferior oblique. Here, the same principle applies, since we know that the left medial rectus works well because we have previously tested. If the left eye does not go in and up, you would know that the left inferior oblique does not work well. Remember that the color of the arrows matches the muscles being used in this frame. So knowing that the lateral and the medial recti both are working well, looking to the right and up evaluates right eye superior rectus and left eye inferior oblique. If you ask the patient to look to the left and up, to achieve this movement, the right eye will use the medial rectus and inferior oblique, the left eye, the lateral rectus, and the superior rectus. If there is a problem, the same principle will be used to determine which is the muscle affected, as we previously described. So, knowing that the lateral and medial recti of both eyes work well, looking to the left and up evaluates the left eye superior rectus and the right eye inferior oblique. If you ask the patient to look to the left and down, indicated here by the target, the right eye will use the medial rectus and the superior oblique, the left eye the lateral rectus and the inferior rectus. This maneuver, in the presence of normal lateral eye movements, look for problems in the left inferior rectus and right superior oblique. The distinction between them can easily be made most of the time by knowing which is the affected eye. If you ask the patient to look to the right and down, the right eye uses the lateral rectus and inferior rectus. The left eye will use the medial rectus and the superior oblique. This maneuver, in the presence of normal lateral eye movements, searches for a problem in the right inferior rectus and left superior oblique. So the answer to this question is B. Next question. Which of the following extraocular muscles produce intorsion of the eye? A. Levator palpebrae and lateral rectus. B. Lateral rectus and inferior rectus. C. Inferior rectus and inferior oblique. D. Superior rectus and superior oblique. The eye moves in three axes: up and down in the y-axis, in and out in the x-axis, and intorsion and extorsion in the z-axis. Elevation is accomplished by the superior rectus and inferior oblique, depression by the inferior rectus and superior oblique, abduction primarily by the lateral rectus, but the superior oblique and inferior oblique may contribute to abduction depending on eye position, adduction primarily by the medial rectus, but the superior rectus and inferior rectus may contribute to adduction depending on eye position, intorsion or cyclotorsion, implying rotation in the z-axis in such a way that the upper pole of the eyeball rotates towards the nose, is accomplished by contraction of the superior oblique and superior rectus. Extorsion or cyclotorsion, implying the upper pole going to the ear, is accomplished by the contraction of the inferior oblique and inferior rectus. Take a few seconds to look at this frame. Notice the little arrows coming out of the big arrows. They indicate the contribution to cyclotorsion of each muscle. The stars indicate the most powerful cyclotorsor in a given direction. So the answer to this question is D. Next question. Looking to the left, which muscle is affected? A. Right lateral rectus. B. Right inferior oblique. C. Left lateral rectus. D. Left inferior oblique. Looking to the left, there is no white in the right eye, but you can see plenty of white in the left eye. The easiest approach to this type of question is to draw the eyeballs and extraocular muscles, as I have done here, and then select the affected muscle. In this case, it is the left eye lateral rectus, the one involved, as indicated here. This patient has myasthenia. Myasthenia is not the only cause of lateral rectus weakness. This patient is looking straight ahead, hence the imbalance between the left lateral rectus, which is weak, and the medial rectus, which is normal, is pulling the eye in. In this patient, the left lateral rectus weakness was due to left cranial nerve 6 compression. This patient also had papilledema. These findings were due to pseudotumor cerebri, to which we will refer at a later class. So the answer to this question is C. Next question. A 49-year-old man presents with diplopia and left-sided ptosis. What is your diagnosis? Take a look at these eye findings and choose among the four possibilities stated. A. Cranial nerve 3 palsy. B. Cranial nerve 4 palsy. C. Cranial nerve 6 palsy. D. None of the above. The first step in answering this question is to determine the muscles affected. The second step is to determine the nerve involved based on the muscles or muscles affected. So let's start with the first step and talk about general rules for detecting the affected muscles. It is an easy thing to remember that obliques do the opposite of what their name indicates, whereas recti do as their names say. Obliques work best with the eye in, recti, that is superior and inferior recti, work best when the eyes are out. Obliques and middle rectus work together. The superior and inferior recti work with the lateral rectus. Now that we know the rules, let's take the first step. Remember, figuring out what muscle is involved is easier if you draw the muscles and their functions below as documented in this frame, and you record the status of each muscle as you go along. Here, eyes are looking to the left, indicating that the right middle rectus and the left lateral rectus are working well. Here, the patient is looking to the right. The right lateral rectus is working well, but the left middle rectus is not working well, as you can tell, because the left eye did not move as expected. Here, the patient is looking right and up, but the left eye is not moving from the primary position. Hence, the inferior oblique is also likely affected. The right superior rectus is normal. Now, we have the patient looking to the left and up. The left eye goes out but not up. Hence, the left eye superior rectus is not working well, but the right inferior oblique is normal. Now, you ask the patient to look to the right and down. You see that the left eye has not gone in and down as it would normally be expected, but instead it has moved down and in the opposite direction. This indicates a normal left superior oblique in the presence of a weak medial rectus. The right eye has moved out and down as expected, indicating normal right inferior rectus. Now we ask the patient to look left and down. The left eye goes out, but not down, indicating a left inferior rectus weakness, where the right eye has moved in and down, indicating a normal right superior oblique. So the right eye is normal and the left eye, medial, superior, and inferior recti, nor the inferior oblique are working. So we have taken the first step and we are ready for the second step, selecting the nerve affected. 3 cranial nerve move the traocular muscles. The most important one is cranial nerve 3. Here we have 3 views of the brainstem. In the posterior view, we do not see the oculomotor nerve. In the lateral view, we can see it, and in the anterior view, we can see the right and the left cranial nerve 3. Here, looking at the brain from below, you can see the right, third, and there are some fibers from the left cranial nerve 3 visible. You can tell it is cranial nerve 3 by its origin from the interpeduncular fossa. This is a cut of the midbrain at the level of the superior colliculi. In it, you can see the Edinger-Westphal nucleus, which houses the parasympathetic neurons for the pupillary sphincter and ciliary muscles. The oculomotor nerve nucleus, fibers of the third cranial nerve, the red nucleus, substantia nigra, the ventral tegmental area, and the medial longitudinal fascicle. As you know, the muscles innervated by the oculomotor nerve, here represented in green, are the levator palpebrae, the superior rectus, the inferior rectus, the medial rectus, the inferior oblique, and the pupillary sphincter. The ciliary muscle is also innervated by the third cranial nerve, but we cannot evaluate its function by the method so far applied. Hence, we will leave it out of the discussion at this time. The second nerve is cranial nerve 4. I have brought the different views of the brainstem specimen back to show you cranial nerve 4. The trochlear nerve is the only cranial nerve that exits the brainstem through the back, so you can see it in this view. You can see it here as it curves forward, and perhaps here. Looking at the brain from below, you can see it here. This is a cut of the midbrain at the level of the inferior colliculi. You can identify the superior cerebellar peduncle decussation, the periaqueductal gray, the medial longitudinal fascicle, and dorsal to it, the trochlear nerve nucleus. I have now traced the trajectory of the trochlear nerve intraparenchymal and extraparenchymal fibers. Notice that it originates contralaterally to its intended target, the superior oblique muscle. In this diagram, I am now adding the superior oblique muscle, which I have just colored, and added the Roman 4 to indicate that it is innervated by cranial nerve 4. The third nerve that innervates extraocular muscles is the abducens nerve. The abducens nerve is the lowest cranial nerve for extraocular movements. You can see it clearly here and here. In this view, you can see it here and here. This is a brainstem cut going through the superior cerebellar peduncle and pons. I am now indicating to the facial colliculus, the abducens nucleus, the intraparenchymal abducens nerve fibers. Here you have the facial nucleus whose confused fibers go back looking for 6 and then realize that they cannot go out that way and decide to go forward, as you can see here. On the other side of the abducens nucleus, we have the medial longitudinal fascicle. Now, I will go back to the list of extraocular muscles and cranial nerves to add the lateral rectus, color the lateral rectus, and add the nerve innervating it, the 6th cranial nerve. Now, when we look at the left eye pattern of weakness, we can easily adjudicate the abnormal movement to a third nerve palsy. But in addition, in this patient, we find left upper lid ptosis, indicating weakness of the levator palpebrae, and a dilated left pupil, indicating pupillary sphincter involvement. These findings further reaffirm the presence of cranial nerve 3 involvement. And indeed, the patient had a third nerve palsy with contralateral hemiplegia secondary to midbrain fungal abscess, as you can see in these images. So the answer to this question is A. Next question, cranial nerve 3 lesion can occur in the dash A. orbit, B. cavernous sinus, C. superior orbital fissure, D. all of the above. These are the basic structures you need to recognize in order to understand the clinical manifestation of cranial nerve 3 involvement. The innervation of the medial rectus, inferior oblique, and inferior rectus is straightforward. Fibers from the ipsilateral cranial nerve 3 motor nucleus cross the midbrain parenchyma, travel through the interpeduncular cistern, enter the sagittal sinus, enter the orbital through the superior orbital fissure, and inside the orbit form the inferior branch of the oculomotor nerve and go to the muscles previously listed. Now let's look at the innervation of the superior rectus. The innervation of the superior rectus is peculiar. The fibers for this muscle arise from the contralateral cranial nerve nucleus and swing to the other side. Once on the other side, they follow the same trajectory as those that we mentioned for the other three muscles previously explained, except that they reach the superior rectus by way of the superior branch of the oculomotor nerve. The innervation for the levator palpebrae is equally peculiar because it originates from a midline somatic motor subnucleus of cranial nerve 3 nucleus, as indicated here. The rest of the course is similar to the fibers for the superior rectus. The innervation of the sphincter of the pupil is also peculiar for two reasons. It arises from a midline parasympathetic nucleus, as shown here, called the Ehringer-Westphal nucleus. The second thing that makes these fibers peculiar among other fibers in the oculomotor nerve is that, as expected for preganglionic parasympathetic fibers, they leave the oculomotor nerve to make contact in the ciliary ganglion with a second parasympathetic neuron before reaching the pupillary sphincter and the ciliary muscle. Now that we have described the trajectory of cranial nerve 3 fibers, I will first list the 8 possible sites of cranial nerve 3 involvement that produce rather distinctive findings. The first one is called nuclear. The second one, fascicular red nucleus. The third one, fascicular cerebropeduncle. The fourth one, cisternal. The fifth one, cavernosinus. The sixth one, superior orbital fissure. The seventh, orbital cavity. And the eighth, the ciliary ganglion. So the answer to this question is D, all of the above. Next question. A patient with evidence of cranial nerve 3 damage and contralateral rubral tremor is likely to have a fascicular lesion. A true, B false. As you know, lesions in 8 segments of cranial nerve 3 produce rather distinctive presentations. Condition number 1. Nuclear lesions. Nuclear lesions produce ipsilateral complete cranial nerve palsy, implying all extraocular movements normally produced by cranial nerve 3 activation will be gone, as well as parasympathetic function. But in addition, we will find contralateral superior rectus paresis as a consequence of the peculiar birth of the superior rectus fibers in the contralateral cranial nerve 3 motor nucleus. In these patients, we will also at times encounter ptosis. Nuclear lesions are very rare in life, but often found in exams. Number 2, fascicular cranial nerve 3 lesion at the red nucleus and superior cerebellar peduncle. This lesion is called Claude syndrome. This syndrome occurs with ipsilateral complete cranial nerve palsy, contralateral tremor, and ataxia. At other times, lesions involving the red nucleus, instead of involving the cerebellar peduncles, involve the substantia nigra. This is called Benedict syndrome, and it courses with complete ipsilateral cranial nerve 3 palsy, contralateral tremor that is often overshadowed by the presence of chorea. Number 3, in this condition, cranial nerve 3 fibers are damaged as they go through the peduncle, involving corticospinal and conticobulbar fibers. Patients with this condition have complete cranial nerve 3rd lesion and contralateral weakness. This is called Weber syndrome. Number 4, cisternal cranial nerve 3 involvement has 2 types of presentations. One called medical, the other one surgical. In medical cisternal cranial nerve 3 involvement, there is incomplete ipsilateral cranial nerve deficit, sparing the pupil. Here you can see a representation of a segment of the optic nerve, decreased diffusion of oxygen and nutrients to the interior fibers due to arterial narrowing, at times produced by thrombosis, produces this syndrome. Medical cisternal cranial nerve 3 involvement is most often seen in patients with diabetes, and as we previously mentioned, is referred to as medical third. The second variant of cisternal third nerve cranial lesion is called surgical. Surgical cisternal third nerve lesion produce complete cranial nerve involvement, the pupils being affected. This syndrome occurs as a consequence of compression of the parasympathetic fibers that travel in the periphery of the oculomotor nerve, some believe dorsally in the nerve, more so than ventrally. This is often due to aneurysm of the posterior communicating artery and presents with sudden onset of headaches. Surgical cranial nerve 3 also occurs in patients with uncal herniation. I saw this drawing many years ago and I still remember it. This drawing depicts the pupillary findings linked to uncal herniation. Take a few seconds to look at this drawing. Notice the patient is intubated. The position of the affected eye is down and out. Notice the presence of mydriasis and the consensual reaction to light of the contralateral pupil. The 5th location is the cavernous sinus. The cavernous sinus is certainly an interesting structure. It surrounds the pituitary. It harbors the carotid artery, which is also found above it, and it rests on the sphenoid sinus. Cranial nerve 2 is above it. Cranial nerve 3 is embedded in its wall, as is cranial nerve 4, the ophthalmic branch of cranial nerve 5, and the maxillary branch of cranial nerve 5. Cranial nerve 6 hangs around in the middle of the sinus with the carotid artery, which is surrounded by sympathetic plexus. Cavernous sinus third nerve palsy is usually complete. Involvement can be painful or painless. Other cavernous sinus related nerves may or may not be affected. A peculiar situation may occur when involvement of the sympathetic fibers traveling the carotid plexus are a major feature of this condition. In such instances, the eye deviates down and out as correspond to a cranial nerve 3 lesion, but the pupils are small, as would be seen in patients with Horner syndrome, as you can see in this frame. But more often, pupils are enlarged and vessels in the conjunctiva are prominent and tortuous, as you can see in this frame, or the ipsilateral eyelid is swollen as a result of venous obstruction. The 6th site of cranial nerve 3 involvement is the superior orbital fissure. Superior orbital fissure lesions usually produce complete cranial nerve 3 palsies. Cranial nerve 4 and 6 and the ophthalmic branch of 5 may be involved, but the maxillary branch of 5 is never involved. The ophthalmic vein usually is involved. This is a photograph of the right orbit. In it you can see the optic canal, superior orbital fissure, and inferior orbital fissure. This is a sagittal cut of the orbit. The circle just introduced corresponds to the superior orbital fissure. The ophthalmic division of the trigeminal nerve or the subsequent branches of the ophthalmic division go through it. The small circle I introduced just below the superior orbital fissure is the inferior orbital fissure. The maxillary division of the trigeminal nerve or its branches go through it. You can also see in this frame the proximity of the cavernous sinus to the orbit. I am now pointing to the ophthalmic vein. Thrombosis of this vein produces chemosis, and at times a sausage-like appearance in this vein can be seen in the orbital CT scan. The seventh possible location of cranial nerve 3 involvement is the orbit. Cranial nerve 3 orbital lesion can produce complete third nerve palsy with or without cranial nerve involvement of cranial nerve 2, or partial palsies with or without cranial nerve 2 involvement. This is the view of the orbit with the landmarks you have already seen. Here I have included some of the content of the orbit to indicate the superior branch of cranial nerve 3 and the inferior branch of cranial nerve 3. The superior branch innervates the reverse lobe palpebrae and the superior rectus. The inferior branch innervates the middle rectus, inferior oblique, and the inferior rectus. The structure I am pointing to is the ciliary ganglion that, as you see, arises from the inferior branch. Hence, in cases of orbital pathology involving the third cranial nerve, sometimes the superior branch may be affected, producing ptosis and up-gaze weakness, but other times the inferior branch is involved, producing full cranial nerve 3 palsy with minimal or no upper gaze weakness and no ptosis. In patients with orbital pathology, swelling of the eyelid is usually present, as you can see here, and an increase in orbital content is often noted, as indicated here. Sinus pathology, a frequent cause of orbital pathology, can also be seen in this CT scan. Chemosis is often present with orbital lesions, as well as proptosis. In this case, you can see the mesial mass compressing the orbital content, and again, sinus opacification. The eighth site of cranial nerve 8 involvement is the ciliary ganglion. Hence, only pupillary abnormalities are present in this site of involvement. Ciliary pathology produces what has been called iris pupil. I will explain iris pupil in the next few minutes. This is a sagittal view of the orbit. Here, indicated is the inferior branch of cranial nerve 3. Through it, the ciliary ganglion receives the preganglionic parasympathetic fibers originated in the Edinger-Westphal nucleus. Here, I am pointing to the entry of sympathetic fibers from the superior cervical ganglion. These fibers, unlike the parasympathetic fibers, go through the ganglion but do not make contact with neurons in it. Nasociliary nerve fibers also go through this ganglion without contacting any neurons in it. They do so to innervate the region of the skin of the nose, in front of the septum, and also the lateral wall of the nasal cavity. I will explain the relation of the different fibers and make a diagram explaining them in the next few frames. The structure in the middle of the frame represents the ciliary ganglion. The Edinger-Westphal nucleus through cranial nerve 3 send preganglionic fibers that synapse with ganglion parasympathetic neurons. The great majority of ganglionic neurons in the ciliary ganglion send axons to innervate the ciliary muscle, here represented in purple. And only a few, represented in green, send axons to the pupillary sphincter. I have represented this numerical difference by the width of the lines going to each muscle. This is an important point, as you will soon see. The axon of the postganglionic parasympathetic neurons form the short ciliary nerve or nerves. Remember, short ciliary nerve shortens the pupil diameter. In addition, sympathetic fibers from the superior cervical ganglion going through the carotid plexus go to the ciliary ganglion, but as we previously mentioned, they do not make contact with any neuron in it. These fibers innervate the pupillary dilator. These fibers are called the long ciliary nerve or nerves. Remember, the long ciliary nerve makes pupil diameter longer. The third type of fibers that is involved with the ciliary ganglion, as we previously mentioned, are those from the nasociliary nerve. These fibers go through the ganglion, but as sympathetic fibers, the sensory fibers do not make contact with any neuron in the ciliary ganglion. They just pass through primarily to supply part of the nose sensation. So what happens when the ciliary ganglion is sick? Only neurons become affected, hence only parasympathetic deficit will occur, and clinical manifestation will vary over time. So we can talk of early, implying the first few days after injury to the ciliary ganglion, late, about 20 days after the injury, and very late, about 3 months after the injury of the ciliary ganglion. Let's start with early and go back to the complete normal diagram to start our explanation. The death of ganglion parasympathetic neurons involve a proportionally equal number of neurons whose axons go to the sphincter of the pupil and to the ciliary muscle. Early phase of this condition is thus dominated by death of these neurons. With the death of neurons' body, their axons also die, leading to ciliary muscle and pupillary sphincter weakness. During this early phase, the pupil on the affected side, if the condition is unilateral, as it usually is, will be dilated if compared with the healthy pupil. Shining a bright light to the larger pupil will show no direct response. Consensual response will be normal. Conversion will have no effect on the larger pupil, but will make the normal smaller to begin with pupil even smaller. So we have looked at what happens early. Now let's look at what happens about 20 days later. From early, where we left our narrative, we go to late. Late start with the surviving parasympathetic neurons in the ciliary ganglion re-innervating the ciliary muscle and pupillary sphincter. Yet the re-innervation of these muscles do not occur perfectly well, since neurons for the ciliary muscle to begin with, as we previously mentioned, constitute most of the neurons in the ciliary ganglion, and only a few are destined for the pupillary sphincter. When the time comes for the surviving neurons to re-innervate the pupillary sphincter and the ciliary muscle, most of the pupillary muscle fibers are re-innervated by nerve fibers from neurons that prior to the injury innervated the ciliary muscle fibers. Notice that in this diagram, the line going to the pupillary sphincter is purple and thicker, representing the aberrant axons going to the sphincter. The consequence of the aberrant innervation of the pupillary sphincter by nerve fibers originally intended for the ciliary muscle have great clinical significance. If we examine a patient about 20 days after the onset of symptoms, the affected pupil will still be larger than the normal pupil. When light is shined in the affected eye, no direct response will be present, but consensual response will be normal. So far, all is the same as it was in the initial exam at the beginning of the injury. But when converging, the previously large pupil becomes smaller than the normal pupil and stays so for longer. It is from this persistence that the term tonic pupil is derived and the term aris tonic pupil arises. So we know what happens at about 20 days, let's see what happens very late, usually 3 months after the first clinical manifestation. Here, I will only dwell on the clinical findings because the explanation as to why these clinical changes occurred is not clear. After about 3 months or even longer from the initial symptom, the pupil becomes smaller and irregular, as you can see here. Light produces contraction of some but not other sectors in the affected pupil. Convergence makes the pupil very small and it stays contracted for a long time. So Addis pupil is nothing more than an aberrant reinnervation of pupillary sphincter by fibers originally intended for the ciliary muscle, which often involve one eye but may become bilateral. Addis syndrome includes the same pupillary manifestation and pathology, but in addition there is loss of deep tendon reflexes in all 4 extremities. So the answer to this question is A. Next question, which of these 2 patients is more likely to have a mass lesion, A or B? This drawing represents a normal segment of the optic nerve with normal irrigation. A compressive lesion is likely to damage peripheral located parasympathetic fibers. Thus, in addition to extraocular muscle paresis, the patient will have dilated pupil. This occurred in patients with aneurysm of the posterior communicating artery, and patients usually present with sudden onset of headaches. But it can also occur with uncal herniation, as we have previously explained. This again is a representation of a normal segment of the optic nerve. Here I am representing a thrombotic plaque obstructing the irrigation system of the optic nerve and sparing the peripheral, including the parasympathetic fibers. In these cases, we see an extraocular abnormality but not pupillary findings. This is most often seen in patients with diabetes. This is called a medical third. So the answer to this question is B. Next question, which is normal? Take a look at this photograph and decide which of them is normal, A, B, or C. In the first patient, eye's position is normal. The light reflex is seen in the center of both pupils. Although this boy's eyes tend to look cross because he is looking slightly to the left and the bridge of his nose is broad, the presence of a normal light reflex confirms that his eyes are straight and aligned. Patient 2 has esotropia of the left eye. The light reflex is central in the right eye and over the medial side of the iris in the left. The third patient has esotropia, described as an inward turning of the eye. Esotropia is the most common type of strabism in infants. This patient has esotropia of the right eye. Notice that the light reflex is central in the left eye and over the lateral side of the iris in the right eye. So the answer to this question is A. Next question, falling while walking downstairs, likely due to cranial nerve dash deficit A3, B4, C5, D6. When walking downstairs, both eyes are looking down and in. The main muscles for looking down and in are the superior obliques. When the superior obliques, or at least one of the superior obliques, is damaged, the inability to look down and in is mainly apparent when the patient walks downstairs. Hence, they tend to fall when doing so. The nerve that innervates the superior oblique is the fourth cranial nerve. So the answer to this question is B. Next question. A child with right superior oblique weakness will tilt the head to the right. A true, B false. Normally, when a child is looking straight, the eyes are aligned and the equator of each eye, as represented by the black lines, are in line with each other. When normal child head is tilted to the left, then the equators of each eye are no longer in line, but they remain parallel to each other. This is sufficient to maintain single vision. This position is achieved by extorsing the right eye and intorsing the left eye, as I have now represented here by the arrows in the baby's figure and now in the eyeball figure. Extorsion of the right eye is due to mainly contraction of the inferior oblique with some contribution of the inferior rectus. Intorsion of the left eye is due mainly to superior oblique contraction with some contribution from the superior rectus. What happens when things go bad? This is a picture from an English newspaper. The article title is "Mom Saved Daughter Life as Doctor Find Brain Tumor After Wonky Neck Video." Notice the position of the neck. With weakness of the right superior oblique, the unopposed healthy right inferior oblique produces extorsion of the right eye, as depicted in this frame by the position of the equator of the right eye, as indicated by the black line. Notice the position of the black line in the normal eye. I have now introduced a white arrow in the baby's figure to emphasize that the right eye is extorsed, and I have done the same in the eye figure for the same purpose. At this stage, the child will have double vision. When the head is turned to the left, right eye is already in the position required to produce single vision. And then when the left eye superior oblique contracts, as well as the superior rectus, then the left eye will intort normally, bringing the equator of both eyes in parallel, leading to single vision. The Athens Eye Hospital put out these drawings, which I find very telling. The top figure represents a child with weakness of the right superior oblique looking straight ahead. Notice the right eye is higher than the left. You can tell by the presence of whiteness below the iris and by the lower position of the light reflex on the right eye than on the left eye. The middle drawing depicts what happens when the head is tilted to the right side, the side of the injured superior oblique. As you can see, when the head is tilted to the bad side, the eye abnormality becomes more noticeable. In the third drawing, the head is tilted opposite to the eye affected. As you can see, the light reflex in the left eye and the right eye are now centered. So the reason she tilts is to achieve single vision due to right eye superior oblique. Posterior fossa tumor is the frequent cause of fourth cranial nerve palsy producing superior oblique weakness. So the answer to this question is B. Next question. Please take a look at this picture and answer where in the oculosympathetic system is the lesion. A. From the hypothalamus to the nucleus of Busch. B. Nucleus of Busch to superior cervical ganglion. C. Superior cervical ganglion to eyeball. To answer this question, all you need to know is that FON stands for first order neuron, SON for second order neuron, TON for third order neuron, and the trajectory of the oculosympathetic pathway. I will start by introducing some anatomical structures involved in this pathway. This is a posterior view of the brainstem. You can see the midbrain pons and medulla. Above is the hypothalamus. The structure I just introduced represents the spinal segment C8 to T1, corresponding to the spinal center of Busch. The structure just introduced is the lung, now the subclavian artery. The carotid artery system includes the common carotid artery, the external and internal carotids, and the ophthalmic artery. This funny looking structure is the trigeminal ganglion with its three divisions and the three branches of the ophthalmic division. One of these divisions is the nasociliary nerve. I will explain this structure in the next few frames. You can see here the trigeminal ganglion, the mandibular branch or third division, the maxillary branch or second division, and the ophthalmic branch or first division. The frontal nerve, the lacrimal nerve, and the nasociliary nerve are clearly represented in this drawing. I hope this funny structure is now clear to you. I will use the label NCN for nasociliary nerve. I am now introducing the eyeball with the eyelids, the pupillary dilator, and the tarsal muscles of Mueller. I will now introduce FON, the first neuron in the oculosympathetic pathway lives in the hypothalamus, and their axons travel in the central sympathetic pathway through the brainstem until reaching the ciliary spinal center of Budge. There, they meet SUN. In the nucleus of Budge, the second order neuron live. These neurons send axons forming the thoracic sympathetic trunk that for a short while travel in the brachial plexus, going over the tip of the lung, under the subclavian artery, and ascending in the common carotid until reaching the level of the carotid bifurcation. There, the fibers find TON, the third order neuron. In the superior cervical ganglion, some of the neurons at this ganglion send axons that travel with the external carotid artery to supply the pseudomotor and vasoconstrictive fibers of the face, while others ascend in the carotid artery, departing from it by jumping into the ophthalmic artery to innervate the muscle of Mueller. A branch of the nerve going to the muscle of Mueller innervates the lacrimal gland and orbital vessels. In addition, and most importantly for our narrative, the ascending sympathetic fibers branches out by hopping along the nasociliary nerve for a brief distance prior to leaving it and innervating the pupillary dilator. These sympathetic fibers, as previously discussed, go through but do not make contact at the ciliary ganglion and are called the long ciliary nerve or nerves. Now I'd like to call your attention to FON. When FON goes bad, we get Horner syndrome that not only involves the eye, as illustrated here, by ptosis and miosis, but also sweating of the face on the same side is deficient. This may be caused by any lesion involving the central sympathetic tract. It is often seen in patients with cervical syringomyelia, as shown here. This condition is often associated with loss of pain and temperature sensation in a cape distribution, as shown here. This is due to involvement of the crossing spinothalamic fibers. So that is for FON. Now I will address SUN pathology. In this frame, you can see a right Horner's. Notice that the increased vascularity due to involvement of the sympathetic orbital vasomotor fibers. Lack of ipsilateral facial sweating is also present in these patients with Horner's due to second order neuron involvement. Second degree neuron Horner's is often due to Pancoast tumors, as illustrated here and shown here. So we finish with SUN, we will go to TON. Third order neuron involvement occurs with the same ocular manifestation, usually facial necrosis is absent. This patient has a right Horner's and weakness of the right side of the tongue. Here you can see a three-dimensional carotid angiography. You see segmental narrowing and dissecting aneurysm of the internal carotid artery. I have introduced this representation of the neck to show the sympathetic chain. Here is the superior cervical ganglion and their axon climbing in the internal carotid artery. I have now indicated the hypoglossal nerve and with a red cycle signal the proximity of the third order neurons, axons, and the hypoglossal nerve. This proximity explains the concomitant occurrence of Horner's and tongue weakness. This is so despite the presence of lack of skin rubor on the side of the affected pupil. The lack of skin rubor usually indicates involvement of the sympathetic fibers traveling with the external carotid artery. Such involvement usually indicates a second or first neuron involvement. Yet, in this case, tongue involvement and angiography supports involvement of the postganglionic neuron. So the answer to this question is C. Thank you very much for your attention.